Hello, everyone, and welcome back to the Pediatric Dentistry webinar series. My name is Omar, and I am the webinar director at SCORE Committee at IADS. It's a pleasure to have all with us. It is a pleasure to have you all with us today for the second session of this series. Before we begin, I would like to introduce International Association of Dental Students, IADS, briefly. It's a global organization that connects dental students worldwide and promote academic exchange, professional development, and international collaboration. This webinar series is organized under the SCORE Office of IADS, the Standing Committee on Research and Education, which focuses on research, education, and global engagement. Through SCORE initiatives, students have the opportunity to learn from experts and expand their academic experience. We are pleased to continue this pediatric dentistry series, a specialty that plays a key role in promoting oral health from an early age and ensuring positive dental experiences for children. We hope you will find today's session insightful and beneficial. It's our pleasure today to welcome our distinguished guest, Dr. Ahmad. He is an associate professor of pediatric dentistry and dental public health at Beirut Arab University, where he also serves as assistant dean and academic coordinator for postgraduate studies. Dr. Ahmed has extensive experience in both academic and clinical fields of pediatric dentistry. He holds a PhD in pediatric dentistry and as a fellow of the International College of Dentists and the Bayer Academy. With a strong focus on pediatric oral health and dental public health, he has contributed to research and publications in the field. We are truly honored to have you with us today, Dr. Ahmed. The floor is yours.
Thank you, dear Omar. I will start sharing my screen. I hope now my screen is visible for everyone. Again, good morning, everyone. I am Ahmad Tarabaih from Beirut Arab University, and I'm honored to be here with the IADS core team to discuss the emerging trends in pediatric dental pain research. As you know, we have all seen a child's fear at the sight of a needle. But what if the future of our specialty was entirely needle-free? So in the next 60 minutes, we will explore how AI-driven diagnostics, virtual reality distractions, and bioactive materials are redefining the painless dental visit for the next generation. Before I start, I declare that this presentation is with no financial support and that I don't have any financial interest in any commercial product or services that I will discuss. And this presentation is only for educational purposes. So, firstly, let's all agree that oral health allows individuals to smile, to speak, to eat, and to socialize without discomfort, without pain, and even without shame. So, as being a pediatric dentist for around 15 years practicing in Lebanon, I have noticed that pediatric dentistry is a specialty for everyone. As long as the patient is cooperative, everything goes well. But as soon as the patient starts crying, the image of the dentist starts to be like a monster in the patient's eyes. And the first question, why this happened? The first reason that comes into our minds, it's simply due to pain. So in this presentation, I will try to answer these four main questions. Do really children feel pain? If yes, what is the definition and the burden of pain? What are the risk factors and the impact of pain? And what are the advancements to alleviate pain in a pediatric dental practice? So, do really children feel pain? Rosalind Ray, in her textbook, The History of Pain, in 1993, stated that, historically, children were thought to be able to withstand pain and discomfort better than adults. Since it was found, or it was taught, that children's immature nervous systems are meant that they didn't feel pain the same way as adults. Also, it has been said that young children don't have any memory of pain and therefore do not suffer long-lasting effects from experiencing pain. Fortunately, research refuted all of these myths. Indeed, children can feel as much pain as adults do and might suffer even more because they cannot rationalize and cope with pain as well as adults do. So all of these myths or of these statements were falsely said. Where painful medical or dental experiences, along with minor everyday pain experiences such as bumps and falls, are likely to play a significant role in shaping the individual's experience of pain and future events. And let's not forget that pain during dental treatments is regarded as an important associated factor for the development of dental fear and anxiety and the dental behavioral management problems in children and adolescents. For example, delivering pain-free dental care for children is very important, since such positive experiences can inoculate children against dental fear and anxiety. So this would give rise to a latent inhibition. So how could we define pain? Is pain only related to a pathophysiological cause, such as an obvious tissue damage? The answer is no. There is also a psychological aspect of pain, where if a patient experiences an event as painful and they report it in the same manner as pain caused by tissue damage, it should be accepted as pain. Therefore, pain was defined recently as an aversive sensory and emotional experience typically caused by or resembling that caused by actual or potential tissue injury. So both psychological and the physiological causes and must be considered. I will talk a bit here in these next few slides from a dental public health perspective, and I will discuss the epidemiology of pain. Starting with the prevalence of dental pain among children and adolescents. Out of around 800 studies, only 97 publications were included in the final meta-analysis that was published in 2021 to estimate the prevalence of global and regional dental pain among children. And the results were as follows. In terms of geographic location, studies from Africa had the highest pooled prevalence of dental pain, of around 50%. Then comes Asia, with a pooled prevalence of around 38.6%, followed by the majority of the studies that were from South America and North America, both with a pooled prevalence of 31%, where the least values of prevalence of dental pain were from Europe and Australia of around 22% and 20% respectively. in terms of gender. The prevalence estimated among males was marginally less than females, with a 34.2 and 34.6% respectively. In terms of age, the histogram shows that the highest prevalence is among the 6 to 12 years children, where this could be explained by the fact that most dental problems would occur at this age group. Then it decreases gradually, but still higher than the children that are aged less than 5 years. So as children grow up, the prevalence of dental pain may decrease a little bit. And this could be explained by the fact that also that children, as they grow up, they could start to better cope with pain as their cognition level increases. What about the cost of dental diseases? And from this graph, we can conclude that prevention is a major measure that should be implemented worldwide. Why? Because as you can see, that the economic burden usually includes the economic burden of dental diseases includes direct costs, such as treatment expenses, indirect costs also, such as productivity losses due to work and absenteeism. Also, it includes intangible costs, such as pain and issues with biting, smiling, chewing, speaking, and expressing emotions, such as smiling, that all related to social and family activities. So in this graph, you can see that in 2015, dental diseases in total accounted for around 544 billion US dollars. And the cost of dental diseases increased up to 726 billion US dollars in the year 2024. And these numbers are expected to increase more and more, especially in the countries that don't implement suitable preventive measures. What about the risk factors and that are related to dental pain in children? We can categorize them into 4 major categories: the socio-demographic, socio-economic, psychological, and behavioral. A quick discussion of this table. We can say that if older children would definitely experience high prevalence of dental diseases, and that's why children may have higher prevalence of dental pain. Also, we can say that the lower income households that are related to the socioeconomic factor, these low income households are disproportionately affected by dental pain. And this is due to reduced access to dental services, due to higher treatment costs, and limited insurance coverage. Also, if we have communities with lower educational levels, these communities or these individuals will be less likely to be informed about the preventive oral health practices and may have a limited understanding of the need for regular dental visits. Moreover, if an individual have a low paying and a highly stressful jobs, or those experiencing job insecurities, such as in countries that similar to Lebanon, for example, those individuals are more likely to neglect their dental health due to time constraints, due to the lack of dental benefits, or due to conflicting financial priorities. Finally, we can also say that as long as individuals have improper oral hygiene practices or improper dietary habits, definitely those individuals would have a higher prevalence or a higher incidence of having more dental diseases, and especially dental caries, which is considered as the commonest biological cause of dental pain. So, what if pain happened? What is the impact of dental pain on individuals and specifically on children? First of all, definitely dental pain would decrease the quality of life of those children. And the quality of life that extends physical discomfort and encompasses the functional and the psychosocial consequences. And from a dental public health perspective, there would be an impact on the healthcare system and the social productivity. And again, this would highlight the need for preventive and accessible oral healthcare services and education, particularly in the underserved communities. Finishing up with the epidemiology section, now let's move on to the practical part that I think most of you would be more interested of it. And I can understand this very well. Now, let's discuss two of the most significant contributors to fear and anxiety in a pediatric dental practice. They are the needle-related procedures, that is the local anesthesia administration, and the rotary instrumentation, known as the dental drilling. These stimuli are strongly associated with heightened pain perception and with negative behavioral responses in children. Therefore, greater emphasis should be placed on employing techniques and clinical approaches that minimize or modify these triggers, with the aim of reducing fear, reducing anxiety, and pain during dental treatment. And I think this should be applied, and this should be the main principle of all of us as dentists in our dental practice, is how to reduce fear, anxiety, and pain during dental treatment for our patients. Before we discuss these two issues, I need to remind all of you of the pre-preparation of patients and the basic management procedures and the importance of the management procedures, whether they were the non-pharmacological behavioral management procedures or even the pharmacological behavioral management procedures. And I will try to include in the next few slides the traditional versus the advancements or the new technologies, especially those that are related to artificial intelligence. So if you want to discuss the non-pharmacological behavioral management procedures, we all know that we have the traditional procedures that could be implemented, including modeling, like desensitization, like distraction, like tell-show-do technique, the most popular technique. In addition to these procedures or approaches, there are advances in artificial intelligence that are that offer supportive tools to further reduce anxiety, where AI-driven systems can deliver pre-visit instructions that help children prepare for their appointments. So you have the AI-powered chatbots and virtual assistants. Simple examples, the Tooth Fairy and the Denteractive. They can provide real-time guidance and respond to common dental inquiries at any time, thereby improving the understanding and the reassurance. Furthermore, you may find you may use the AI avatars that are also known as the mini dentist that can function as an interactive digital extension of the traditional tell show do technique, thus enhancing the patient engagement and reducing fear. Don't forget that all of the approaches related to AI and all the softwares or programs are still need further research. On the other hand, there are the pharmacological approaches, such as inhalation sedation and other forms of conscious sedation that can be utilized to alleviate pain and to reduce anxiety during dental procedures. In many cases, a combined approach integrating both pharmacological and non-pharmacological strategies may be employed to achieve an optimal patient comfort and cooperation. As you can see in this picture, there is the TV, and this from there's the TV, there's the inhalation sedation, there's the eye goggles, sunglasses for distraction, conscious sedation for relaxation. So this is the main aim of our job as pediatric dentist and you as future dentist is to reduce pain and to make your patient happy as much as possible. We begin now by considering the advances in the anesthesia. These advances can be broadly categorized into three main areas: the anesthetic agents, including the topical anesthetic gels or agents, and the injectable anesthetic agents. Also, the second category of these advances in anesthesia includes the local anesthesia delivery devices. And you will see next that there is a huge progress in these devices and improvements in these materials. And finally, we will discuss the non-pharmacological non-pharmacological approaches for local analgesia. So let's start with the topical anesthetic agents from the first category. There are a variety of topical anesthetic agents that are available for use in pediatric dentistry. The following section will highlight the most commonly used agents, and I will discuss most of them. There is the Hurapack periodontal anesthetic kit, the Ceticaine topical anesthetic liquid, the Orakix subgingival anesthetic gel, the glove papaya based topical anesthetic gel, and the Dente patch system. I will give a description for each of these agents, the advantages, and the drawbacks. So let's start with the Ceticaine topical anesthetic liquid. Such liquid is dispensed into the periodontal pocket with up to 60 minutes of topical anesthesia achieved. Main advantage is that gives an increased depth of surface anesthesia, and it is less sensitive to moisture. However, major drawback that there is not enough safety data on pediatric patients. The OraKick subgingival anesthetic gel, it is inserted into the gingival sulcus, where the anesthesia lasts for 20 minutes. It has a rapid onset of action. Also, safety data on pediatric patients still not available. And I think those who are interested in research could benefit from some of these agents to make further research. And the DentiPatch system, it's a lidocaine in this DentiPatch system that diffuses into the mucosa, as you can see in the picture. It is bioadhesive, it gives better diffusion, and an earlier onset and longer duration of anesthesia. However, if you are using these patches in the mandibular area, there will be poor adherence due to the higher salivary flow. Remember, all of these are only topical anesthetic agents. That means that you still need to give an injection later on. The second part is the injectable anesthetic agents. We have 3 injectable anesthetic related advancements. Include the symbiochrodine, the Oraverse, and the pH buffering of local anesthetic solutions. First, the symbiochrodine. It's a quinolone derivative with natural vasoconstrictive effect. It has a longer duration of anesthesia than lingocaine. So that's why they recommended symbiochrodine as a substitute in 12 to 14 years old medically compromised patients for whom lingocaine or adrenaline was contraindicated. However, major drawback that there is no safety or efficacy data on children under 12 years. The Oraverse. It's a non-selective alpha-adrenergic receptor antagonist, the vasodilator. This means it results in an increased absorption of the local anesthetics and thus shortening the duration of anesthesia. Main advantage is that it is considered as an accelerated reversal of the soft tissue sensation from around 2.5 hours to only 1 hour in children aged 4 to 11 years old. Drawbacks of this is that there would be post-operative intraoral pain and swelling, increased blood pressure and paresthesia more in children than in adults. Remember, Oraverse is administered immediately following the dental procedure, usually while the patient is still numb, and then to the same location and using the same technique, whether infiltration or inferior alveolar nerve block, as the original local anesthetics. Okay? And the final one is the pH buffering of local anesthesia. The pH buffering lidocaine, it involves the addition of sodium bicarbonate, and the aim is to raise its acidic pH. That's usually from 3.5 to 4 or 4.7, closer to the physiological pH around 7.4. And this would significantly reduce the injection pain and accelerating onset. The standard method is to add, as we said, the sodium bicarbonate to lidocaine, and that's why if you want to add sodium bicarbonate, the solution needs to be freshly prepared at each time because it loses the stability. So you will prepare this solution, you will add sodium bicarbonate, and usually it is, as we said, 8.4% sodium bicarbonate and a ratio of 1 to 10. So for every 1 milliliter of bicarbonate or 1 milliliter of bicarbonate to 10 milliliters lidocaine. So for every 10 milliliter lidocaine, you will add 1 milliliter bicarbonate. So it's better to be used at chair time, to prepare at the chair side immediately before the injection. The second part in the advances, or the second category, is the delivery devices of local anesthesia. We will discuss the computer-controlled local anesthesia delivery and their advancements or the AI-driven new instruments, jet injection, the vibrotactile devices, the intraosseous anesthesia, and the insulin syringe. Firstly, the computer-controlled local anesthesia delivery device, or the CCLAD. These systems, they are dental devices such as the wand STA, as you see it in the picture, or the DentaPen. Usually they use a foot pedal and a computerized unit to deliver anesthesia at a slow, constant, and controlled pressure. One of the main disadvantages of these systems is their cost, and maybe it could be time-consuming to set up and to disinfect. Perhaps the advanced computer-controlled local anesthesia delivery, the AI-driven systems, would be more applicable, where these AI-driven relaxation tools, such as the Sleeper One from USmile, the Quick Sleeper from Dental High Tech, and the Diva Systems, is truly an advanced computer-controlled local anesthesia delivery tools, specifically engineered to modernize the injection process in pediatric dentistry. So these tools would help to administer pain-free anesthesia to young patients, thus reducing fear and discomfort. Three main advantages of these AI-driven tools. First, dynamic pressure sensing. This means that such systems use real-time sensors to monitor to monitor tissue resistance. So if the pressure exceeds a certain threshold, which is what causes the stinging sensation, then the systems automatically adjust the flow rate to keep it below the patient's pain threshold. Second main advantage of these AI-driven tools is that there's a precise flow control. This means that it delivers the anesthetic solution at a constant slow rate, often as precise as 0.02 milliliter increments, thus preventing the rapid tissue expansion that traditionally causes discomfort. And the third main advantage is the ergonomic pen design. Unlike the traditional syringes, such system would often you would often use a lightweight pen-like handpieces. Definitely, it is less scary for children and and allows the dentist to use a more precise rotation technique during needle insertion. The second device is the jet injector, where anesthetic solution delivered using a high pressure and velocity that penetrates through the oral mucosa. So it gives a faster onset of anesthesia, more patient acceptability. However, it is expensive, it is bulky, it causes an abrupt noise and pressure sensation that could induce anxiety. There could be a risk of residual hematomas at the injection site. But such case, or in cases if you have a complicated surgical procedures due to its long duration of action and better pain control, so such jet injectors could be used. Next, we have the vibrotactile devices. Such devices are based on the gate control theory of pain. What does that mean? It means that when vibrations are applied alongside to an anesthetic injection, these vibrations will reach the brain before pain sensation and thus reduces the pain. A good advantage is that these devices has a painless injection. However, one of the disadvantages is that there could be discomfort associated with the sensation of vibration. We have the VibraJect, for example, as one of the vibrotactile devices. Next, we have the intraosseous anesthesia, where local anesthetic solutions are injected directly into the cancellous bone adjacent to the tooth to be anesthetized. This would result in an effective, localized pulpal and periodontal anesthesia without an extensive collateral soft tissue anesthesia. The intraosseous anesthesia, by the way, it is recommended in cases where you have an MIH, a molar incisal hypomineralization affected teeth, where these teeth usually have severe hypersensitivity. So the intraosseous anesthesia could be beneficial in these cases. The main advantage is that it gives lesser volume of anesthetic solutions. However, there is a difficulty to locate the perforation site and there is pain at the injection site. And as you can see, there are many systems and many advances in the intraosseous anesthesia, starting from the Stabident system or the X-tip from Dentsply Sirona. These systems need firstly to make a hole and then to give anesthesia in it. However, the intraflow system allows penetration, injection, and withdrawal using a simple one-step technique without the need to relocate the perforation site. The last one is the insulin syringe. You are all familiar with it, I think, definitely. It is a 30 gauge short needle. Definitely, it is visually appealing and cost effective in comparison to the other devices. However, if you have an inferior alveolar nerve block, such syringes due to the short needle length wouldn't be applicable. The last part of anesthesia is the non-pharmacological approaches to local analgesia. So remember that these procedures or these approaches, these techniques are most non-drug procedures. So we will talk about low-level laser therapy, triple LT, acupressure, the Buzzy device, the cryoanesthesia, virtual reality analgesia, and we will differentiate between virtual reality and the augmented reality. The electronic, and finally the electronic dental anesthesia, or the EDA. Starting with the low-level laser therapy. It suppresses painful sensations by temporarily disrupting the sodium-potassium pump system and biomodulating the dental pulp. It is minimally invasive, anti-inflammatory. It has an anti-inflammatory and an analgesic effect. However, the low-level laser therapy is primarily used, it's contraindicated in patients with epilepsy, pacemakers, and remember, since the profound anesthesia is not achieved, so the low-level laser therapy is used as an adjunct to reduce the pain of the injection itself. So we cannot count on it entirely. And to provide, because it provides some pre-operative analgesia rather than completely replacing the injection for deep or invasive procedures. The Buzzy device. Such devices are based on gate control theory of pain and distraction. They are effective behavior guidance modalities. They are well accepted by children. However, in some instances and with some cases, the appearance like a bee may potentially draw a negative reaction from some children. So you should be cautious when introducing these devices into children, especially young ones. The cryoanesthesia is also based on the gate control theory of pain. They use the tetrafluoroethane refrigerant spray. It gives an instantaneous anesthesia. It is safe. It is cost effective, not expensive. However, it has a short duration of action that is sufficient to reduce the discomfort caused by needle insertion. The AI driven virtual reality and augmented reality. As I said, AI technologies like VR and like augmented reality AR would definitely, or they assume, to alleviate fear and anxiety in pediatric patients. So this would create an immersive and an engaging experiences during dental procedures. So AR superimposes digital information into the physical world. However, VR generates immersive simulated environments to the patient. So the VR analgesia, it uses sensory shielding where the brain is flooded with sensory inputs from the VR, thus less attention available for pain stimulus. It is an effective behavior guidance technique tolerated by patients. However, VR could induce nausea, could be discomfort due to the larger head-mounted displays. In this slide, I will show you two videos that were recorded at the pediatric dentistry clinics at the Beirut Arab Universities, both using VR tools, and you will see that patients are very relaxed. So the local anesthesia procedure was easy and simple. And in the second one, you will see that the patient is very relaxed. He's enjoying the movie. And even you can see his hand that's shaking and moving with the song. And his head is moving alongside with the song. So thanks to our doctors for these two beautiful videos. Local anesthesia administration becomes more easier, more fun, and the total experience definitely for those little kiddos would be good, would be fine. And this, as we said before, would help in the latent inhibition or the inoculation if they had good experiences during their earlier ages. So the last part is the electronic dental anesthesia, the EDA. They are analgesic effect that's based on the gate control theory of pain and an endogenous opioid theory. They depend or they have depend on the principle of TENS, which is the transcutaneous electrical nerve stimulation. In such cases, the superficial nerves are stimulated by pulsed electric current that is delivered across the intact skin surface via electrodes for localized pain relief. As you can see in the picture in the right side of my slide, these electrodes are placed over the coronoid notch and posterior mandibular area for the administration of the inferior alveolar nerve block injection. Definitely, there would be no post-operative anesthesia. That's the main advantage of the EDAs. However, they are contraindicated in apprehensive patients, those with cardiac pacemakers, those with cerebrovascular problems, and epilepsy. Remember, while EDA can completely replace the need for injection, and this is the only one of all other devices, but it is often used as an adjunct to make injections painless or is sufficient on its own for complex or surgical procedures. So if you have any simple or minor procedures like simple extractions, for example, simple cavities, for example, and if you are planning to use the EDA, you can use them because such procedures are not extensive, they are minimally invasive, and there would be no need for a local anesthetic injections. Now, finishing up with the anesthesia issue, let's move on, and I will move on to the drilling issue, the rotary problem. So first, I want to remind everyone that now there's a new philosophy that is now applied in the era of modern dentistry. And there was a paradigm shift from the G.V. Black principle, which was extension for prevention, into now in modern dentistry, the principle is prevention of extension. These principles give us the minimal invasive dentistry, or the MID, where the main aim of MID is to preserve healthy tooth structure and uses techniques like remineralization, fissure sealants to manage decay. So it covers both prevention, starting from diagnosis, prevention, and if there is true cavities, then we should deal with them in a minimal invasive way. In this topic, I'm more interested of true cavitation and how we can treat this true cavitation in these young children patients without causing pain, or at least minimal pain in comparison to other traditional techniques. So in case we have true cavitation, and this is due to failure in the prevention strategies that were performed before it, then two trends of minimal invasive dentistry can be used. The silver diamine fluoride with its modification, and I will talk about it, and the stainless steel crowns modification, especially the whole technique. Starting with the silver diamine fluoride. A meta-analysis published in 2019 and was available on PubMed Central by 2020, talking about silver diamine fluoride. Results of the such meta-analysis can be summarized as follows. Silver diamine fluoride is safe with no serious adverse events. It is effective because studies showed that silver diamine fluoride would arrest 80% of cavitated lesions. It is efficient because it is applied in less than 1 minute. Also, silver diamine fluoride can be applied by any health professional in any health care society or community setting. Silver diamine fluoride requires minimal preparation in less than 1 minute, unlike other treatments. Silver diamine fluoride, it is minimal invasive, it is painless, it is truly effective, it's affordable for everyone. It is, but the issue of it is that intervention should be as soon as the problem diagnosed. And in this case, you will gain the effectiveness of silver diamine fluoride. So here are some recommendations to use silver diamine fluoride. The 38% solution is more effective than lower concentrations. Twice a year application is more effective than yearly application once a year. And the application time ranging from 10 seconds to 3 minutes maximum. And you will achieve success. And this means that this seems that silver diamine fluoride doesn't seem to be time dependent. Also, silver diamine fluoride is effective in large lesions. Occlusal lesions, and those with visible plaque have less chance of arrest while we use silver diamine fluoride. So, first of all, as we said before, as soon as the cavity is diagnosed, should be treated with silver-diamine, and don't wait until the cavity gets larger and bigger. Secondly, before applying silver-diamine fluoride, it's better to do a prophylaxis to remove the visible plaque. Its use should be avoided in teeth with suspected pulpal involvement, definitely because there will be failure in such cases. Also, regarding the issue of teeth, it was seen that anterior teeth have higher success rates than posterior teeth. And as you said, the annual application seems to be effective to arrest and prevention of root caries on older adults as well. Here are some pictures for the silver-diamine application. As you can see, the main disadvantage of silver-diamine is the staining. So what we can do to overcome the staining issues, the potassium iodide is used in dentistry, which was originally as a salt. And now there are products that combined silver-diamine fluoride with potassium iodide. So we use it in combination with silver-diamine fluoride in order to mitigate the black staining caused by the silver-diamine treatment. So when the potassium iodide applied immediately after the SDF, the potassium iodide would create a silver iodide precipitate that minimizes discoloration and at the same time without severely reducing the antibacterial effectiveness of the SDF. New advancement also in the product itself. There is the, instead of having liquid, now SDF is available in the form of a gel. So with the same percentage, 38% silver-diamine gel. It's a thickened formula and oftenly it has a blue color. Definitely it gives better control than the liquid SDF. So this would reduce the risk of staining adjacent teeth, the risk of dripping or saliva dilution. Often it's used in 0.1 milliliter unit doses or 2.8 milliliter syringes. Another procedure where you can minimize the staining and take advantage of the glass ionomer, which is the silver modified atraumatic restorative treatment or the SMART technique. And a recent randomized controlled trial was conducted at Beirut Arab University to compare the SMART technique versus the gold standard technique, which is the ART, the atraumatic restorative treatment. As you all know, mainly it depends on the application of glass ionomer and the impact of both techniques on the quality of life among a group of children in Lebanon. And here are some photos from the study. And the conclusion of this study was that SMART technique demonstrates slightly higher success, but importantly, there wasn't any case that have a pulpal involvement. And also, SMART technique improved the quality of the children life, unlike the ART technique. Now, the stainless steel crowns. This is another technique that we can use it as a minimal invasive technique to treat cavities. And it is the whole technique. So from this, our whole technique just was developed in 2009, And here are some slides. I will go fast on them. About them, the advantages of whole technique. It's a non-invasive procedure in which the crown is cemented without the need for local anesthesia, without even caries excavation or tooth preparation. It's quick procedure that limits the child's anxiety. Whole technique is considered as a less traumatic technique for the child. If you want to compare it with the traditional placement of of stainless steel crown, it seals in the carious lesions. So we'd have a proper marginal seal from the stainless steel crown, and this could arrest caries or at least slow it down. It improves pulpal health. It increases the access to dental care, decreases the percentage of untreated dental caries, and deliver restorations that will permit natural tooth exfoliation. It's more cost effective than conventional restorations. Here a table that shows you the indications and contraindications for the use of whole technique. Make sure that whole technique is contraindicated in teeth with signs or symptoms of dental infections or irreversible pulpitis. So in cases you have pulpal involvement, you need to excavate caries, you need to clean the decay before placement of the crown. If you have teeth that are considered non-restorable, so definitely the crowns in general will not be indicated. And in very young children who do not understand the procedure or to tolerate biting the crown into this position without local anesthesia. Here's the criteria of whole technique success or failure. So the success and the failure criteria of conventional restorations and whole techniques, according again to Ennis et al. In 2009. The success definitely is to have normal tooth exfoliation, whereas the major failure is to have abscess or pulpitis that indicates extraction or pulp therapy. This is a nice systematic and meta-analysis in September 2022, assessing the evidence of whole technique. The results of this meta-analysis was that whole technique is over 49% more likely to succeed when compared with other caries management techniques. It is more likely to succeed when compared with restorations. Whole technique reduces the risk of failure when compared to other caries management techniques. Whole technique should be the MID technique of choice in cases of proximal or multi-surface lesions. Nothing is perfect. So the main disadvantage of whole technique is that whole technique would induce an increase in the occlusal vertical dimensions. So definitely this would result in discomfort post-operatively. However, the present reviews found that this increase in the occlusal vertical dimension resolves over the time and tend to be not detectable after 12 months. So this fortunately would happen, but in the first perhaps few weeks, there will be post-operative discomfort. The final thing in minimal invasive restorations is the use of robotics in pediatric dentistry. Now it's trendy, the AI-driven robotic systems that are enhancing the pediatric dental procedures, making treatments less invasive and more precise. How these robotics work? The AI-assisted robots, such as Lupin Dental and LaserBot, they guide dentists in performing minimally invasive procedures with greater accuracy. the lupin dental, just to say that the lupin dental is an experimental robotic system that has successfully performed automated tooth preparation, but it is still under strict human supervision. Whereas the laser bot, it's a specialized microbot that uses a femtosecond laser rather than a traditional drill to remove decay and to prepare teeth for crown. It is a small tool that enough to be mounted directly into the tooth to compensate for patients. Here are main benefits of robotics in pediatric dentistry. Definitely less invasive treatments, faster healing times, reduced discomfort during procedures, and improving accuracy and minimizing the risk of complications. While not to forget now that robotic dentistry is still evolving, and its potential to transform pediatric dental care is enormous. So most of these trials are experimental, are still in their experimental phase, or in the early human trials. And the future definitely is for them. So, as a conclusion for everything, we can say that dental pain is a global public health problem that affects people's well-being, health system, and society productive processes. Yes, pain is harmful and should be avoided, especially in children, because children do really feel pain and they shall not be ignored. And the amount of pain research on pediatric population in dentistry is scarce, as we have seen. And so we need more well-designed primary studies before guidelines on pain management strategies for pediatric dental care can be formulated. I will end up my presentation with a picture of my hometown in Bekaa Valley. I send you all my sincere regards from our beloved country, Lebanon. Thank you for your time. And if anything pops up later, feel free to drop me a message or connect in LinkedIn. I'm always happy to chat. Thank you.
Thank you, Prof. Ahmed, for this informative and beneficial presentation. So we have some questions. So one question is, what are the main barriers to translating pediatric dental pain research into routine clinical practice?
The main barrier to translate research into practice,
Yes.
mainly I think a research area is very vast and everyone can think of anything, but the main problems could be perhaps the cost of these materials, instruments, the applicability, the safety. Before For example, before starting randomized control trial, we have to check if these materials are truly safe. So there's a long journey to prove that these new instruments are truly effective. And that's the good thing of research, is to continually making new improvements, new advancements. Uh, so yes.
So the second question, Doctor, as a general dentist, how can we stay updated with the emerging evidence in pediatric pain management?
It's There's an old saying says that to be professional is nothing but being a continuous student. So even the seniors or even the senior dentists, anyone If anyone wants to be always updated, so must always read, follow up the journals, read articles, check every once in a while the new guidelines from different academies, pediatric academies in the world, such as the European Academy of Pediatric Dentistry, the American Academy of Pediatric Dentistry, the ORCA, the CARES Organization for CARES Research. So if you want to be updated, you have to read always. And this is my advice for all the junior and the prospective dentist. You have to read.
So, at the end of this session, on behalf of IADS Score, I would like to sincerely thank you, Dr. Ahmed, for this insightful session and for sharing your expertise with us today.
Thank you very much. Thank you, IADS. Thank you, everyone. Have a nice day.
You too, Doctor. So, we have now 5 minutes to scan your attendance.